Welcome to our second webinar in our series. So my name is Claire Joy. I'm the chair of the CSF Leak Association, and one of our charitable aims is working towards swift and accurate diagnoses and effective treatment for all individuals who are suffering with CSF leak symptoms. So whether you're joining us now live or later on a catch-up on one of our YouTube channels or our website, we're thrilled to have you here. So thanks very much for attending. So we're going to look at another section of the UK guidelines for spontaneous spinal CSF leaks, and we're going to explore how the diagnosis of SIH is made and what other diagnoses may be considered. And then at the end of the presentation, we're going to have a Q&A, and we'll just have a bit back and forth. So with that in mind, I'm delighted now to hand you over to my co-facilitator for today, and that's Dr. Sanjay Cheema. He's a consultant neurologist at the National Hospital for Neurology and Neurosurgery, and he's now running the CSF leak service there. He's also the lead author of the UK SIH guidelines and is quite knowledgeable. So thank you so much, Sanjay. I'll hand over to you.
Thanks, Claire. Great to see so many people online again for the second webinar in the series. So I've got the honour of introducing Dr. Brendan Davies, who's going to talk to us today about the symptoms and clinical assessment of patients with suspected spinal CSF leaks, as well as some of its mimics. So Dr. Davies is a consultant neurologist at University Hospitals of North Midlands, based in Stoke-on-Trent, specialises in headache and facial pain disorders, and is the clinical and research lead for the regional headache clinic there. He's the current chair of BASH, which is the British Association for the Study of Headache. He's been involved in trials for other headache conditions and an advisor to NICE. And he was also part of the UK Specialist Interest Group, who developed guidelines for spontaneous intracranial hypotension, as well as for idiopathic intracranial hypertension. So he will talk to us about the symptoms and clinical diagnosis of patients with suspected spinal CSF leaks. So I'll hand you over to Brendan now.
Thank you very much, Sanjay, and thank you very much to the CSF Leak Association for inviting me to speak to them to you today. It's my pleasure to do so. I'm going to try and cover a few things. I'm going to try and cover some clinical stuff. I'm going to cover some a bit of kind of physiology, and then I'm hopefully at the end going to deal with some questions, which actually is probably going to be the most difficult thing in terms of today. So let's move forward. I thought I'd start with a little bit of some boring stuff, some CSF anatomy. I think it's important if you're going to be thinking about CSF leaks to actually understand a little bit about why it might happen. Our brains are quite complex things. There's a sagittal scan of the brain there, and CSF is produced in the brain by something called the choroid plexus. And actually you produce about 150 to 160 mils every day. And that goes around your body, goes down into the spinal canal, it goes around your spinal cord, and it's circulated, and then it's absorbed again largely in the brain. So the spinal cord isn't somewhere where you would normally absorb things. As I say, you produce about 150 a day, and the importance of this is that some people who might have a CSF leak actually therefore can sometimes be asymptomatic if they have sufficient production of CSF to correct for the amount of CSF they might lose. But actually, it's probably not just a CSF pressure problem, and you're probably aware of the names. Spontaneous intracranial hypotension. Well, another name for it is spontaneous intracranial hypovolemia, because one of the thoughts is that this isn't a pressure problem, it's a volume problem. You lose fluid, therefore you lose volume, and therefore that sometimes has the same thing. So you might hear me say intracranial hypovolemia rather than hypotension. I'll explain that a little bit further on. And the last bit of probably basic science I'm going to talk about is why people might have headache, and people wonder, people are disabled by the headache, but why might they get it? Well, the brain is again a complex organ, but it likes to keep things stable, and there's several compartments. There's a structure compartment, there's a blood compartment, and there's a CSF compartment. So if you lose fluid in one of the compartments, CSF, you'll get an expansion in some of the other compartments. And that's relevant to why the investigations sometimes become abnormal. That's why you might have an abnormal brain MRI with contrast, or you might have swelling of the blood vessels. The relevance of that in terms of pain is that the blood vessels are where the nerves which sense and mediate pain are kept. The brain is not sensate, it's not pain sensitive, it's the blood vessels. So swelling of the brain, swelling of the blood vessels around the brain, inflammation of the lining of the brain are the pain sensitive structures. So things which affect those are probably as important in terms of mediating pain as anything. So we may come back to that. So again, before I talk about the clinical thing, I'm going to give you a bit of a history thing. So how long has this been around? Well, it was 1891 where people started to have something called a lumbar puncture for neurological disorders. And it was 8 years later that people started to report this thing called low CSF pressure volume headache. And that was when people had a post lumbar puncture headache, when they had some fluid taken off. And a guy called Beer, B-I-E-R, described his experience, and I've actually got the description for you here. And for those of you who know someone or suffer from a CSF leak, you'd probably recognize this. And I'd encourage you to quickly read it. I'm going to do that. This is somebody who experimented on themselves, putting lumbar punctures into themselves to see if it led to any adverse headache. And what they found was, initially, having had a lumbar puncture, it made no difference. But then, soon after, they developed a headache, which gradually got worse. Within hours, they became very unwell. And within more hours, it was sufficiently strong and pressure-like that they had to lie down. And when they stood up, it returned. So this is the typical first description of orthostatic headache. And as those with CSF leaks know, having to be forced to take to your bed and remain there, if only for 9 days, that would be a blessing. And this was the first descriptions of low CSF pressure headache. But it was actually only 40 years later that the first spontaneous CSF leak problems were described. So we're really are in early days in terms of the understanding of this condition. And it's only really been about 80 years since this was ever described. What's been awesome in the last kind of 80 years is the progress of understanding and the progress of therapies. You can see I've given you a bit of a timeline here, but it's really only over the last 10 to 15 years have we seen a massive increase in knowledge in relation to SIH. And the UK is now one of the other places around the world with having these webinars. And this has been reflected in the science around this as well. And this is all the publications that have occurred for SIH in the last 20 years. And you can see 20 years ago, if you had SIH, we didn't know much about it, but now we're having 4 times as many publications per year, and we're starting to identify both effective therapies, effective ways of investigating people, and more importantly, why it happens. And actually, if it's not a CSF leak, what should we be doing? So with all of that, I'm going to turn to kind of talking about the clinical things. So those of you who have a low CSF pressure problem or an orthostatic headache or a CSF leak problem are most likely to be in this little group called the spontaneous group. But actually, it's important to know that low CSF pressure headaches or CSF leak headaches don't only occur spontaneously. If there's been a history of a dural puncture, even if it's 20 years ago, post-dural puncture headaches sometimes can manifest as something that's considered to be spontaneous. So it's really important when having your history taken to make sure there isn't a background history of a spinal tap, particularly around a pregnancy, which led to some headache, or even spinal trauma. Because post-dural puncture headache, although similar in phenotype, is managed slightly differently. So we're going to talk about the spontaneous type. And what I'm going to try and do is talk about its main manifestations, talk about some of the chameleon symptoms that occur in people, and then look for evidence to support that diagnosis. But I'm not really going to be covering its management today, and I'm not going to be covering first-line therapies because that's going to be covered in the other webinars. So a little bit about how common it is. Well, it's as common as the more serious acute severe headache disorder, which comes to the emergency department on a regular basis around the UK, and that's subarachnoid hemorrhage. In the United States, they calculated that the prevalence of this is about 5 in 100,000 presenting to an emergency department with a CSF leak disorder. And that's the same as subarachnoid hemorrhage. And subarachnoid hemorrhage in the United Kingdom is a neurological and neurosurgical emergency in terms of its need for assessment. But I don't think we've really got there yet in terms of thinking in the same way in terms of CSF leak. In the community, it's probably a little bit more prevalent, but actually some of it can be self-limiting. So we probably don't know that. But there aren't any big community-based studies. And actually we base most of our ideas about the epidemiology of SIH on possibly biased secondary care studies. So we don't really know the exact prevalence. It's certainly a disorder more of females than males, and it's certainly affects people in the prime of their life, but can occur at any age. And as most of you are probably aware, headache is the most common manifestation, but not the only manifestation. So what we know now is that spontaneous intracranial hypertension, although presenting with headaches, which I'll describe, can sometimes present in much more disturbing ways. It can sometimes present as acute coma, with people having collections in their brains which are not recognizing as being due to spontaneous intracranial hypertension. It can present as acute deafness, sometimes in the absence of headache, but often with muffling and acute sensorineural deafness. There have been descriptions of it presenting as something called a brain sagging dementia or a reversible dementia. And there are presentations of patients who sometimes present with an orthostatic tremor, a body tremor or a limb tremor, which is typically worse when they're erect and often improves when lying flat. And you can imagine that because headache isn't the main symptom in this condition, that these can sometimes be mistaken and not considered within the diagnostic spectrum of SIH. All very rare. But headache is the main manifestation and probably described in between 80 and 90% of patients with spontaneous intracranial hypertension. The commonest presentation is orthostatic, and I'll define that in a little bit in a minute. But actually, there's some rare or unusual headache symptoms. People who, whenever they exert themselves, get a headache disorder, which is self-limiting when they stop exertion. People who just cough or have a triggered headache when they cough should be considered to have possible SIH and an investigation. The opposite of a headache which improves when you lie down and improves and worsens when you stand up, something called a paradoxical orthostatic headache has been described. And it's difficult to try and understand why that might help, because it's the exact opposite of what happens. And one of the thoughts about this is it could be just engorgement of the veins around the base of your brain which does this. But we don't really know why this happens. But this certainly has been described, and we've seen a few cases of this. You can have people who just have a daily headache problem. It's not orthostatic, and some of the studies I'll show you suggest about 15% of people report that they've never had a headache, which gets worse when they stand up and gets better when they lie down. And those typically present to headache services, or sometimes go undiagnosed for long periods. And they're a real challenge for clinicians, because you may not have even thought about that, so you may not do the relevant tests. And finally, there's the classical things that I'm going to talk most about. So these four headache presentations are probably the commonest headache disorders or headache phenotypes that have been described in the context of spontaneous intracranial hypotension. The commonest one is what's called an orthostatic daily headache. That might start de novo, out of the blue, with something we sometimes term as being a new daily persistent headache syndrome. So that's where you develop a new onset headache without obvious reason. Sometimes it might be after minor trauma, or often there isn't any reason. And then for no reason at all, it continues and continues until the person might have had it for several months. It's important if someone presents with a new daily persistent headache syndrome, you request or ask about what happened at the start of this presentation. Because if people say, I had to lie down all the time and I was okay at night, but when I woke up in the morning and stood up, it got worse, it presents that feature that we're all looking for, called an orthostatic headache problem. Headache typically worsening, becoming erect and standing, typically throbbing, typically at the back of your head in the subocciput, and often pain-free on awakening. And that symptom characteristic is fairly classical, and is the red emergency light to make people think about this diagnosis and particularly investigate. What often happens with some of these headache syndromes is over time that orthostatic bit can be lost. In addition, you might find that there's development of background headache. And again, as I talked about the simple cough headache and the exertional headache, people who have this background daily headache, worse on standing, often report that if they cough or sneeze and exercise, it exacerbates it. And finally, there's this group at the bottom, which is called acute thunderclap headache. So in headache terms, if somebody describes an acute onset, worst ever headache starting in less than a minute, so like an acute thunderclap, and persists, the main concern that doctors have if you go to the emergency department is whether they've had a subarachnoid hemorrhage, they've had a bleed into their brain. But actually about 5% of people presenting with spontaneous intracranial hypertension present with an acute thunderclap headache. The typical investigation for acute thunderclap headache, if the CT scan is normal and they present more than 12 hours after onset, is they'll have a lumbar puncture. But the problem is, if they have an orthostatic or postural headache after they've had their lumbar puncture, sometimes the true diagnosis of spontaneous intracranial hypotension gets lost because of the fact they're not sure if it's been the lumbar puncture which has induced this new orthostatic headache, or was it spontaneous intracranial hypotension present in the first instance. So those are the main headache presentations, but actually you can have SIH in some individuals without any headache at all. And we've seen a few of these over the years, and we find it really difficult to explain. So there must be some factor which induces headache symptomatology over and above just having a CSF leak. So headache is the predominant symptom, but I said there were other things, and we call this often headache plus. And these are the chameleons in our clinics. These are the things where we see patients who might present with a headache, worse on standing, or worsens through the course of the day. But they also have other neurological syndromes which might make us think about different disorders to SIH. They might have something called orthostatic gait ataxia. So that's the person who might have a drunken feeling when they're walking and have problems with coordination. But actually their coordination might be all right when they're sitting, or particularly lying, but only when they're standing does that occur. I talked about orthostatic deafness, and I also talked about some movement disorders. One of the questions we've come in has been, can things like Parkinson's disease be caused by a spontaneous intracranial hypertension? Well, I haven't seen Parkinson's disease caused by it, but certainly tremor and unsteadiness, something called ataxia, has been described. I talked about coma, and sometimes these people present with coma, unexplained coma, and they might have something called a Chiari-1 malformation on their scan, and people think it's the Chiari-1 malformation, but it's only when they add contrast and they get a bit of a history beforehand that they found out that this person might have had an orthostatic headache, which had decompensated over time. So those are some of the chameleons. Probably one of the important ones for doctors, which is increasingly being recognized by neurosurgeons, is the young person who presents with acute severe headache and is found to have a brain MRI scan or a CT scan with something called a subdural. And in general neurological terms, people who present with a subdural hemorrhage or subdural hematoma have often been on blood thinning medications or have had a traumatic brain injury. So there's usually a cause. But actually, if you're a young person and you present with features of a subdural on your scan, particularly if you've got a headache problem, then about 1 in 4 of those people have been found in a German study to have evidence of a spinal CSF leak. And now our neurosurgeons, at least at our centre, are educated to be told that if we have a young person presenting with a subdural hematoma in the absence of the usual causes, think about spontaneous intracranial hypertension and think about investigating those. And the yield for that has been much more than we have done in the past. So becoming aware of the chameleons within our neurological practice has been really important in terms of identifying who one might investigate a bit more, even though they haven't got the typical symptoms of spontaneous intracranial hypotension. So this is something I've generated over time because I've just thinking about my experience of seeing people on their headache patterns with spontaneous intracranial hypertension. So one of the things I do in our clinic is get people to draw what happens, what's their behaviors like and what their headaches are like. And I've given these a few kind of acronyms, like yo-yo headache. So this is the person who I typically see who has a headache which worsens on becoming erect, on standing. It's sufficiently severe that they have to lie down and they have a little rest, but they've got to get in with their life a bit, so they get up again and they can bear that for a short period of time. So yo-yo headache is what I typically see in the early stages of acute severe spontaneous intracranial hypertension. Another presentation is what's called SHOD headache, or headache which worsens through the day. And so it's and this is the person who they might wake up feeling fine, but as the day goes on, they get an increasingly intense of holocranial or suboccipital throbbing headache, which is sufficiently problematic that by lunchtime or by tea time, they're having to lie down because it's so severe. And if they're lucky, they'll get to the end of the day, they'll go to sleep, they won't be troubled by at all, they'll wake up headache free, and then they'll go through all this pattern again. So SHOD headache is another important pattern to at least be thinking about as a doctor when we're trying to assess people. There's this thunderclap onset, new daily persistent headache I talked about, abrupt onset, less than a minute headache, which doesn't go away, but actually this person reliably sees improvement if they lie down, and if they get erect again, their headache comes back to them. And then the other patterns, which I've talked about beforehand, is this exertion triggered pattern. It's the person who exerts themselves, they have headache worsening for a short period, they stop their exertion, it resolves. And these people typically present to headache clinics. They're not always scanned. They certainly don't always have brain MRIs with contrast, but actually this picks up a small proportion of people with SIH. Cough headache, the typical short duration cough induces a short duration. But interestingly here, they haven't got headache between. And I can't understand on the basis of why headache doesn't occur in between in this small group of people who have spontaneous intracranial hypertension. It's important to know that exertional headache and cough headache have a number of other causes apart from spontaneous intracranial hypertension. And finally, the last pattern that I see a lot more than I'd like to, the person who presents symptomatically with headache, which is worse when erect, improves when they're lying down. But they then develop this slow grade background headache all of the time because they have to get on with your life, because the investigations may not have shown a cause. They're left with this yo-yo pattern, but actually much more chronic in terms of yo-yo patterning, having to be up for longer, or having to try and be up for longer in order to get through their life. So those are some of the headache patterns that we see in SIH. The other important thing are the non-headache symptoms, which are commonly reported by a number of people. Now, my colleague Sanjay, Dr. Chima, who's on this webinar, has been involved in describing this. And I'm not trying to teach anybody to suck eggs, but I'm sure a lot of people on the webinar will recognize the symptoms that they might experience as part of their SIH, particularly audiovestibular symptoms, the cognitive slowing that occurs, and sometimes pain, spinal pain or interscapular pain, which might be nerve root pain where the leak is, or might be because there's stretching because of traction on the dura. And these have my colleagues at the National have done this beautiful analysis of all the world literature in 2021. And as you can see on the little graph here, the most common symptom in about 85% of all populations has been orthostatic headache. But actually, all the other things are equally as important, because some of these other symptoms are equally as disabling as this headache, which worsens when you stand up. The fact that simple analgesics and other therapies don't tend to improve it just makes that symptom manifestation even worse. And that's been followed up by German groups who've identified similar things. A Swiss group identifying that auditory symptoms, head pain symptoms, cognitive symptoms are all very, very common. Neck pain being seen in at least 2/3, and nausea being a prominent symptom as well. And the importance of recognizing all of these is you can understand why sometimes these people are mistakenly diagnosed as having migraine, because migraine can be all over, can have visual disturbance, which you see in about 41% of people with SIH, can have nausea, prominent nausea, can have vomiting, sometimes can have gait instability, can have noise sensitivity. So all those things are seen sometimes in attacks of migraine. So chronic migraine is sometimes one of the commonest misdiagnoses, but the orthostatic aspect to the headache is missed. And what was really interesting in this retrospective study of people with confirmed CSF leaks is that 15% of people just didn't ever have orthostatic headache, telling us if we only think about people with orthostatic headache as having this condition, we're probably going to miss some of those diagnoses. So being open to the chameleons in the clinic is really important. So do diagnostic criteria help us or hinder us? Well, actually, I've just given you again some history. In 2011, we thought you had to have a low CSF opening pressure. I'll come back to that because that's incorrect. Does sustained improvement of symptoms after epidural blood patching make it more likely? Well, actually, in my clinical opinion, it doesn't. I think a blood patch response is helpful and might support the diagnosis, but I don't think it's diagnostic of spontaneous intracranial hypertension. Now, that's something my colleagues may challenge me on, but I've certainly seen people who haven't got CSF leaks benefit from having epidural blood patching, and any procedure can have a placebo response. What's good about this criteria, it involves the important radiological features of brain sagging and pachymeningeal enhancement, probably the most useful radiological features supportive in the diagnosis in terms of making the diagnosis. Again, no recent dural puncture and not explainable by another disorder. All of our criteria for diagnoses have that. If there's an alternative explanation, we use it. This has been summarized a bit further by in 2018, these are the up-to-date International Headache Society classification criteria for headache attributed to SIH. I actually think these are a step back, they actually are less specific for SIH, because low CSF pressure is definitely not something we see on a routine basis in people with SIH. At least 50% of people can have normal CSF opening pressure, and it doesn't necessarily identify investigations which prove evidence of a CSF leak. So I think these are less good than the previous ones. So I talked about CSF pressure and I talked about CSF volume. And why did I do that? Well, I did that because of this paper which came out of the United States, which looked at a population of patients with proven spontaneous intracranial hypertension due to a CSF leak. They had an MRI positive, or they had an identified CSF leak on CT myelography. And what they found was that CSF opening pressure was less than 6, the level of which is considered to be significant, in only a third of patients. So if you use that as your diagnostic criteria, a low CSF opening pressure alone, then you'd miss the diagnosis in about 2/3 of patients. And what was really interesting is CSF opening pressure was more than 20 in 5%. So CSF pressure alone is an erroneous test. It's not useful on its own. You could actually argue that the only reason you might do CSF analysis in the diagnostic workup of somebody with SIH is you're looking for an alternative condition rather than looking for this condition. There may be some questions on that. So we don't routinely do lumbar punctures in our population of suspected SIH patients because we don't think it gives you any useful yield. The brain MRI scan abnormalities I talked about. I'm not going to talk too much about these because they'll be talked about in your webinar, but these are the important things. You can see this pachymeningeal enhancement, diffuse on sagittal and coronal imaging throughout over the whole brain. You can have descent of the brain, what's called brain sagging, and there are some other features which are a part of the diagnostic brain MRI imaging. So going back to why do you have the headache? Well, the theory as to why people have headache and why they have a lot of their symptoms is that you have sagging of the brain due to low volume or pressure. This causes traction on the pain-sensitive structures over the surface of the brain, which are in the meninges and on the blood vessels. Or you get compensatory vasodilatation of the veins and the blood vessels in the brain. That's why because of that thing I talked about, the Monroe-Kelly hypothesis. And because the pain nerves are on the surface of the blood vessels and on the meninges, you get activation of pain systems in the brain, which give people their relevant symptoms. So that's what we think. Whether that's true or not, I think it's probably a bit more complicated than just simply traction on the structures. So confirming suspected SIH, if you've got the right symptoms, and I've talked about orthostatic headache, I've talked about those chameleon symptoms, I've talked about those other presenting syndromes where we become suspicious, the next step in that is finding some paraclinical evidence to support a spinal CSF leak. Having done that, you need to decide what type of CSF leak it is, and the imaging will do that, and the next webinars will do that. And more importantly, if we're going to effectively treat a spinal CSF leak, we need to identify the exact site. But actually, the bigger problem is sometimes, even if you think it is, all your tests are normal, and they don't identify a leak. And these are the main 3 types of leaks that you may be familiar with. There's a ventral dural tear where your spinal imaging might show something and you might see a bony spur or some bony piercing of the front of your dura. And this used to be thought the commonest things. And you'll see abnormalities often on the spinal MRI in that situation. You might have a lateral tear, which is close to these things called diverticulitis, these swellings on the dura, which is around the nerves. And then the most recent thing, which this graphic from 2016, when it was first described, suggests these only affect about 2.5% of people with SIH. That's the cause of about 2.5% CSF venous fistulas. But actually, it's much more than that. And the more recent data is getting up towards 25 to 30% as our techniques to identify it improve. So it's important when you're potentially seeing your physician, if you have radiological evidence of SIH on your brain MRI scan, is getting your neurologist to kind of have a think, do I think I've got a type 1, a type 2, or a type 3 leak? Because actually that determines the strategies that might be needed in terms of your investigation and your future treatment. So I said there's sometimes the tests are normal. We think it's SIH, but actually the computer and everything else says no. So what can mimic SIH? Well, one possibility is actually there's been a spinal CSF leak. It's resolved, but we're left with something called a spinal CSF compliance problem. And this has been proposed by some of the Swiss groups using some investigations and studies looking at the stiffness of the lining of the spinal cord, this dura, and suggesting that this might become potentially less compliant and adjust the pressure volume ratios and therefore induce symptomatology. It's a theoretical framework. We haven't proven that at all, but that's one of the possibilities that might be explained to you. The second thing is you've got a totally different disorder. You might have a condition called postural orthostatic tachycardia syndrome, or POTS. I'll talk a little bit about that, about one of my next slides, but actually that's a different condition and that can have other symptoms. And there's research going on at the moment to determine whether the headaches people have with POTS are in any way similar to what happens in spontaneous intracranial hypertension. The other thing that's a challenge is you can develop POTS if you lie down for long periods of time because you become deconditioned and your autonomic nervous system doesn't work as well as it should do. So it's important to know that you can develop secondary POTS even if you lie down too much, having had what might have been a CSF leak. And the second thing is there are studies which show people who have POTS can also have a spinal CSF leak. So if the story of an orthostatic headache is really good, investigations should still occur, in my opinion, to look for evidence of a spinal CSF leak. But actually, that might be a double hit hypothesis and there might be two things going on. It's certainly worth getting the investigations for POTS, and I'll talk a bit about that, quickly done in the clinic before you have all your other stuff, because at least we know then if you develop POTS later on, it's secondary POTS as opposed to primary POTS giving you your initial symptoms. There's this other condition called craniocervical instability or cervicogenic headache. My reading of the literature is it's really difficult to find a really good study describing this population and their phenotype. It's mentioned in all the differential diagnoses, but I can't see a really accurate description of what it entails. Certainly, if you've got this condition called Ehlers-Danlos type 2 or a severe inherited hypomobility problem, there's a possibility that laxity and instability around the foramen magnum and the base of the brain where the neck meets could occur. But actually, I think this is something that needs a lot more study to determine that it's a definite different diagnosis. Certainly, structural problems in the neck sometimes can mimic the symptoms of SIH, but I've never seen them as severe with neck problems as they have in SIH. And finally, there's this group of people where we just don't know what they've got. They sound like they've got an orthostatic headache. You've done all the investigations, including invasive investigations for a spinal CSF leak. You've looked for a CSF venous fistula. Their scans are normal. One possibility is it's a primary headache. So CSF leak is a secondary headache. Things like migraine are a primary headache. And are we just seeing a variation of something that we haven't recognized before? And I think there's a lot of work that needs to happen here. And there is a condition called idiopathic new daily persistent headache. And idiopathic is the medical name, is we don't know why. But that needs to have exclusion of secondary causes, including SIH if the symptoms are correct. So I'll leave you with some last slides. Postural orthostatic tachycardia syndrome. So this is something where people don't just get headache, they have other symptomatology. And these are the kind of other symptoms that are really important in this situation. But if you remember those chameleon symptoms I talked about, a lot of them are fairly similar, hence why the two can sometimes get confused. People with POTS typically have symptoms of what's called orthostatic intolerance. They feel lightheaded with prolonged standing. They often get palpitations, blurred vision. They sometimes have non-specific cardiac features, and their symptoms are reliably triggered by standing or by a procedure called head-up tilt, and significantly improve with recumbency. So fairly similar in some ways to spontaneous intracranial hypertension, but in SIH, the headache is much more disabling and predominant, whereas the other symptoms of orthostatic intolerance, in my experience, are more problematic in POTS. How do you diagnose this? Well, you can do the kind of cardiology test where you have something called a tilt table, where they put you initially at horizontally, and then they put you to 60 degrees, and they keep you there for about 20 to 30 minutes doing pulse and blood pressure on a regular basis. And they look at at what happens to your pulse and blood pressure with 60 degrees head up tilt. And what should happen if you have POTS is your blood pressure, which should stay the same, but your heart rate might increase by 30 beats a minute, and do that within the first 10 minutes of head up tilt. If you're a child, it should be 40 beats per minute faster. So the example being is if your background resting pulse is about 80, it should go to at least 130 and remain there with head up tilt. Your cardiac rhythm should be fine, and you shouldn't have any other cause for doing that. And people with POTS often have a baseline resting tachycardia. Their heart rate often at rest is quite fast. And this has been studied, and this is looking. This is quite a little interesting thing. This was a little while ago now. I haven't put the date on. I apologise for that. And they actually took people. 25 people. This is the largest study of POTS, and they took people who had normal non-crossed brain MRI. Lots of these didn't have headache, and of the 24 people, 40 of them not having had any orthostatic headache. What they found is if they gave them head up tilt and they kept them for up to 10 minutes on a head up tilt for 60 degrees, they found that by 9 to 10, about 2/3 of them developed this headache within 10 minutes of being upright. So actually, it's certainly the case if you've got POTS that you can have an orthostatic headache. But what isn't clear is whether you have a sustained orthostatic headache. They often have a short-lived headache, and there's a much higher prevalence of migraine in the POTS population. So I'm going to wait for my colleagues at the National Hospital, who are just about, I'm hoping, to present or publish something on POTS phenotypes. But actually, what's really useful is they've gone and looked at all the literature about POTS. And actually, what's really useful is that they have suggested that actually there's just not enough documented evidence to be sure that the phenotype of orthostatic headaches in people with POTS is the same as that in SIH. So we're going to watch this space. So to conclude, I've been a headache neurologist for 24 years. I've seen lots of advances in headache medicine in that time. And the one thing that causes me the most difficulty in my day-to-day practice is probably assessment and diagnosis of people with spontaneous intracranial hypertension, particularly when the imaging doesn't show what I'm expecting it to show. I think it's probably been difficult to recognize for general neurologists, and certainly emergency departments and other places don't see that. I think it's imperative for patients to be part of a multidisciplinary team approach to this. And I think it's important to recognize that just because it's orthostatic doesn't mean it's always a leak. I think collaborative working in the team you see is imperative. And it's important to recognize that although your doctor might not be able to tell you what's wrong with you, he's just as frustrated as you are. I think it's important to probably recognize what I call one of the medical principles of first do no harm. One of the things that I have to struggle with on a day-to-day basis is when the MRI scan of the brain and the spinal cord MRI scan are normal, and we thought it was SIH, the patient's convinced they've got a CSF leak, is why won't we do a CT myelogram? And I'll answer some questions about that if you want to. And I think it's important for me to acknowledge that I'm equally as frustrated as anybody who's probably attending this seminar about why can't I get better? And part of that is definitely neuroradiological technical expertise. And part of that is actually some of the shared decision making that's probably happening in the UK now through CSF leak pathway development. And I'm really thankful to the CSF Leak Association for giving me the opportunity to be involved in this. I think these patient initiatives in collaboration with clinicians is the only way forward in this condition, as we hopefully understand the disorder more and try and improve everybody's well-being. Thank you for listening to me. I hope I haven't bored you.
Thanks very much,
Thanks
Brendan.
so
You
much,
definitely,
Brendan.
I'm sure you haven't bored anyone. That was brilliant, especially highlighting some of the uncertainties and the gaps in knowledge and where we're not certain about things at the moment, especially in those imaging negative patients that you mentioned. And I agree that the MDT and collaborative working is the way forward, and I found it very rewarding working with the CSF Leak Association on the guideline that we produce, but also on these webinars. And it's often something patient has said in clinic that will cause us to think of new research questions or things that we haven't thought about before. So yeah, I think working with patients is going to be key. We've had lots of questions which have come in advance of the webinar, and we've also had some on the Q&A. If anybody has any more burning questions, please post them on the Q&A in the next few minutes, because we'll probably have to have a cut-off after that. We've got about half an hour to go through some questions that we've had in advance and the ones that have come in so far. Claire, did you want to kick off with a question?
We've got one here of do symptoms vary depending on the type of spinal CSF leak, and in particular, can the back pain occur more with a venous fistula?
So the answer is yes. So back pain with a CSF fistula, I don't know the answer to that. I'm not aware of a CSF fistula giving you more back pain than the other causes. So this is a little bit about reporter bias. So there aren't huge numbers of populations who've been published with CSF venous fistula. They're kind of single center reports. And one of the centers has suggested that patients with CSF venous fistulas might have more triggered headache. So they might have more cough, a cough and Valsalva triggered headache. You know, I certainly haven't personally got enough experience to say that would make me think this is a CSF venous fistula versus another type of CSF leak. So my general inclination is that I don't think there's one symptom that necessarily says this is going to be a CSF venous fistula or a dural tear. It just doesn't. It doesn't ring true with me. I think we'd need large populations being compared and studied in order to try and identify something like that. I don't know if Dr. Chima feels similarly or differently.
Yeah, I think similarly. So we'd need hundreds of patients with each type really to properly identify whether that's the case. And we've got maybe tens of patients now, but in a few years, I'm sure people will be looking at this. As you said, the fistulas we've only known about for the last 10 years, and people were not really routinely picking them up till sort of 5 years ago. I think a couple of the complications in our experience might be more common with fistulas. So we see the general impression is that patients with sort of big subdural hematomas more often seem to have CSF venous fistulas. And patients with this brain sagging dementia type condition, most of them we found to have CSF venous fistulas, but it's small numbers of patients, so we can't really make firm conclusions.
Yeah. What I will say about and I don't want to steal the thunder of the people in terms of the imaging, is that there's a radiological feature which will make me work harder. If there's brain MRI contrast enhancement, if you have diffuse meningeal enhancement and or subdurals and or severe brain sagging, those three things in the right symptom presentation, but CT myelography is not finding anything, we will keep going with CT myelography to go and look for a CSF venous fistula. And having spoken to some of my American colleagues, that's their go-to. If the brain shows really not some of the measurement things in something called the Burn score, some really definite abnormalities, you need to keep going until you find that CSF leak. And that's one of the things that we've learned specifically in this area.
Brendan, we sometimes have patients who are convinced that the location of the pain in their back coincides with the location of the leak. Is that true in your experience?
No, I'm not convinced by that. I think that's probably just some. I think the back pain is probably some traction on the radicular nerves. I think sometimes it might be at the right site, but again, it goes back to that. It's the reliability of it. If you've got a bony spur, you're probably going to have all kinds of other kind of spinal spondylitic changes, which might give you some stabbing back pain. I just don't think that's a reliable sign.
Fair enough. Thanks. While Sanjay's picking the next question, Brendan, would you mind stopping sharing your slides there?
Yeah.
Yeah, so a couple of people have asked about the more unusual neurological symptoms that you mentioned can occur. How common are these type of things? In particular, someone's asked about speech or swallowing problems, facial weakness, or tremor or movement disorders.
So I think they're very rare. Tremor, I've seen a couple of people with a postural tremor, one of which we investigated really hard for a CSF leak problem and didn't find one. Swallowing's been described. The swallowing, if you have significant brain sagging and you something called your foramen magnum at the bottom, the base of your brain, that can potentially give you swallowing problems because of the fact you can have neurogenic dysphagia. But again, that's not a common one I've seen. And I have to say, I haven't seen a brain sagging dementia. We've got a gentleman who's got dementia and who's got radiological features of SIH, but I think he's unlucky enough to have probably a degenerative dementia and SIH, but we haven't sorted out his SIH yet, so I'm keeping the book open there.
Great. Another question from a patient then: if the eyes of a patient are swollen in the morning, could that be due to a CSF leak?
I think it's highly unlikely. I think it depends. There's two bits of swelling you can have. If it's around your eyes, periorbital swelling, I think there's all kinds of things that can do that. I think there's all kinds of things that can do that. I think if they're thinking about swelling at the backs of their eyes, what's called papilledema, that's definitely not low CSF pressure volume. That's suggestive of high CSF pressure or an alternative cause of optic disc swelling, and that needs investigation in a different way to SIH.
Can you talk more about the relationship between CSF leaks and IIH?
Okay, yes, so SIH, there are certainly cases of SIH who have previously had something called intracranial hypertension. So there are two types. In the same way as there's low CSF pressure and low CSF volume syndromes, there's spontaneous ones and there's ones which might have been induced by a surgical procedure. You can sometimes have high pressure syndromes, and a high pressure syndrome typically gives you headache, which is the exact opposite, typically worse lying, worse when you're flat, might wake you up from sleep, improves with getting erect. And you'll have swelling at the backs of your eyes. There's a condition called IIH, which typically involves young, overweight females with menstrual irregularities, which is probably a metabolic problem. At least the literature is starting to suggest that. And a proportion of those have been described as having had remission of their IIH, their raised pressure syndrome, and the development of SIH. So there's certainly a relationship. I don't think there's a causal relationship. I think it's more likely that a proportion of people sometimes develop a CSF leak who've had IIH. We've had a patient who's gone the other way, who has had a low pressure syndrome, not spontaneous, that was induced by a shunt, and then they've been overweight, and having had their shunt and everything resolved, they've developed a high pressure syndrome. So there's definitely cases who have moved from one way to the other, but I don't think it's a common thing. It's just to be aware of. The only other area that becomes important is in the treatment aspect. So the patient who might have had an epidural blood patch, so you're giving them a large volume, 20 to 40 mils as an epidural blood patch, and they see a change in their headache pattern. And a guy called Peter Krantz has described this beautifully in the United States, where instead of having their suboccipital headache, it becomes a generalized headache or a bifrontal headache. It changes in characteristic. It's no longer worse when they lie down. It's not worse when they stand up. It gets worse when they lie down. They just don't want to lie down, and that lasts for several days after their blood patch, and then improves again. One of the things that can rarely occur in SIH is that after epidural blood patching, they can have something called CVST, something called a cerebral venous sinus thrombosis, and there have been rare case reports, but these are exceptionally rare.
Thanks, Brendan.
Too much talking.
A couple of people have asked about headaches in the sitting position. So with orthostatic headache, we usually think about difference between lying down and standing up. So if a patient had, for example, a headache that was worse going from lying to sitting, or sitting to standing, or sitting down for a prolonged period of time, are they things that would make you think of low CSF volume headache or not?
Certainly patients, that on its own wouldn't make me think about that, but certainly people who have post-dural puncture headache, that's the first thing they do, is they've been lying in bed, they sit up, and then they suddenly, before they get up, realize I've got a headache sitting up. So I think headache when sitting, your head's still higher than your spine. So it's just I'd expect it to be less. And if you stay sitting all day, it's the same thing. You know, you're erect.
Yeah.
A few questions have come in with patients describing fluid from the nose or blocked sinuses or metallic taste in their mouths. And I wonder if you could just speak a bit about what that might indicate.
Okay, so fluid from the nose, if it's clear fluid from your nose, you don't really need to worry that you've got a spinal CSF leak. That's the general thing, because fluid from the nose could be because you've got a blocked nose. Fluid from your nose could be because you've got acute rhinitis, which is probably the commonest cause of fluid from your nose. If you're having it in the context of a severe headache, there's in migraine or some other headaches, you can have something called cranial autonomic symptoms, where you can have clear fluid coming from your nose. If it's related to a headache which you think is postural, then fluid from your nose usually implies a cranial CSF leak. and cranial CSF leaks don't tend to present in the same way as spinal CSF leaks. Cranial CSF leaks present with recurrent meningitis and with other things, sometimes fluid from your nose, but actually they don't present with orthostatic headache. And that's been published recently about. Sanjay, I don't know if you agree or disagree with that.
Yeah, correct. Yeah, I'd agree with that. Yeah, I think so. Everything you've said. Some people have asked about predisposing factors for SIH and whether there's any genetic conditions that could predispose patients for CSF leaks. And then there's a link question.
So I'm not aware of any published data on the genetics of SIH. I haven't seen any at all, so I don't think there is any. There things like Ehlers-Danlos type 2 and Marfan syndrome and these elastic tissue disorders and hypomobility syndromes. There's certainly multiple authors suggesting they predispose, and we certainly ask about that, and I think it's reasonable to do so. But I'm not aware of any genetic studies, and there's certainly no genetic test. If you've got one of those conditions and you develop an orthostatic headache, it might raise the suspicion a bit more. And then you go into this murky water of what's it called? Cervical instability. And I just want somebody to come and give me a lecture about that, because I've never heard somebody talk about it sensibly. I'm sorry if I'm a bit dismissive of that. I just want somebody to come and teach me about that, because when I talk to people about it, they can't give me a good anyway.
Yeah, there's a link question, which is somebody who has Marfan's and has dural ectasia. They've not been diagnosed a leak, but had some symptoms suggestive of this. Is dural ectasia either likely to cause their symptoms or to cause leak, spinal CSF leak?
I'm gonna say I don't know.
Yeah.
And I think it's probably important for me to say that. Probably one of the things I didn't talk about is that all the people who are tuned into this webinar are probably going to come across their neurologist and come there, and you'll ask that neurologist questions. He doesn't know. I'm relatively senior, I think. I'm relatively knowledgeable, but I learn every day of my life. And one of the things that is really difficult is to give a good advice when actually you don't know the answer. And I think it's important for me to convey the fact that sometimes there's uncertainty. And when there's uncertainty, we try and make the right decision about first doing no harm, not exposing somebody to investigations that can have bad outcomes. And when I get asked a question like that, the first thing I do is I'll probably go and PubMed it or go and look up the literature and say, okay, what's written about this? And that's the best thing you can do with your neurologist is try and encourage him to be curious, because if nobody knows everything, and if you find the person who knows everybody, can you tell me, because I'm going to send my people to him.
I do think it's fair to say you had a really good graph showing the amount of interest in and publications in SIH and that they're rapidly increasing over the years. But I think it is a fair comment to say that that doesn't necessarily mean that all the neurologists in the country are up to speed with all of the research and all of the changes and all the developments. And I think it's just kind of a comment on that you can't be across everything all the time. So. No.
And I have to say it's an exciting area to be in, but it's a really challenging area to be in. And I'll be fascinated by the radiology, because that's where the technical skills and the advances have largely gone. But actually we've talked about the collaboration, but it is a collaborative process. You need to have a clinical neurologist in collaboration with a good neuroradiologist to get the best outcome for everybody, in my opinion.
Totally.
Claire, have you got another one?
Yeah, I've got one about that just came up today. Is there any association with CSF leaks and cavernoma or syringomyelia. Apologies if I've not pronounced those correctly.
So cavernoma, no. Syringomyelia, probably no. The thing where syringomyelia can be confused is syringomyelia commonly co-associates with a Chiari malformation, and so Chiari malformation in association with syringomyelia is usually not due to a CSF leak. So you can have what's sometimes called an acquired Chiari, where people think they've got a Chiari-1 malformation, but it's due to brain sagging. The only time an association with a low CSF pressure volume problem becomes an issue is if that person with the syrinx has had a shunt put in place. Because if they've been shunted, it raises the possibility that they might have a secondary low CSF pressure volume problem as opposed to a spontaneous problem. So okay. That's the importance about thinking about a syrinx, because sometimes people get shunted because they've had some neurosurgical things, and that's one of the things they sometimes do.
Okay.
There are a couple of other associations that people have asked about. One would be jugular venous compression, whether there could be a link to that. Well, I think there's 3 or 4 questions about that, so just
okay.
What you'd say.
Well, you don't want to answer that first, do you, Sanjay? So I don't know that, I have to say. So the jugular vein and the valves in the jugular vein has been implicated in cough headache as well, I think, if I remember rightly. There's been some literature about that. So I'm not familiar with that literature. So I'd have to say I don't know, but I'll go away and read now.
Yeah, I'm not sure either. There's a question, just because I don't think it's going to be mentioned in the other webinars, but in terms of conservative management of patients, and are there any medications or other things that you recommend to patients to manage that may help manage their symptoms?
Okay, so if I'm going to presume, so there are 2 groups of people. There's the group of people who've got radiological features of spontaneous intracranial hypotension, and they've got the right symptoms and they're fairly disabled. So I'll manage those with blood patches. I will manage, I'll encourage them to have oral caffeine, because there's even a Cochrane review with 26 patients saying it works. So so I'll do a bit of that, and I'll regrettably we'll put the foot on the bed up, and I'll try and encourage them to do recumbent exercises so they don't necessarily decompensate from an autonomic function point of view. And I think what we haven't got is we haven't developed a leaflet for that, and I think that's something that would be really useful to develop for everybody. So that's for the people who are radiologically, and the frustration I've got with them is that they're waiting for their tests and they're waiting for all the interventions, because that's what they need, and that's my biggest frustration there. And then there's the group who are negative. You know, I don't think you have got SIH, or the tests aren't saying you're SIH, and what do we do with those? And I will manage those in 2 ways. If there's any hint in the background that they have a background history or a family history of migraine, I'll look for those things, and I will think about using preventatives that I sometimes use in primary headaches. Sometimes use tricyclics. I sometimes use beta blockers. If they've got POTS, I'll certainly think about using beta blockers or engaging my cardiologists, because there's lots of treatments for POTS. There's midodrine, there's ivabradine, there's lots of treatments for POTS independently. So I'll look at those in terms of, can I put them into a primary headache phenotype, even though the tests are normal, or have they got comorbidity, and use those kind of things? Can I, have they got POTS? So if they haven't got a CSF leak, can I engage them with some of the therapies for that? There's some There's some literature from America using bilateral occipital nerve blocks for post-dural puncture headache. So we'll sometimes offer them symptomatic treatment. And I'll say to them, I don't know.
What's your experience of using either the migraine preventive medications or nerve blocks and things like that in these patients where we either can't find the leak or we're not sure whether it's a leak or whether it's a primary headache disorder?
So I personally don't think I haven't tried any of the new CGRP targeted therapies, but the old drugs I just don't think work. I'm doing something because I'm being forced to do something.
To go. Yeah.
Yes, yeah. And sometimes I'm being forced to do something. Occipital nerve blocks, I think, is symptomatic for lots of things. So I think the trouble is that I don't think it gives sustained relief. My biggest struggle here is that you could potentially do anything you like, because there's no evidence to say to the contrary. And I'm frank with people and I say I don't know what to do. If regrettably, as some people say, well, Dr. Davies, do I need to see somebody else? I say probably yes, because of the fact that I've got to the end of where I can get to, and I hate that. I'm passionate about trying to kind of do the right thing, but actually it's really difficult. Difficult area. So I'm happy to be guided if there are other things, but it sounds like you might be in the same situation, Sanjay. I don't know. Is it something you found which is really good?
I don't think there's anything we found which is really good. So we've tried all the same things, pretty much. So definitely some patients have benefited from greater occipital nerve injections, but as you say, it's usually a temporary thing for a few weeks or so. We have some patients who have had a partial benefit from using some of the migraine preventive medications, but it's not amazing, to be honest, the experience. And then we have a handful of patients who have some migraine symptoms that we've either given Botox injections or the new CGRP monoclonal antibody treatments. It's quite small numbers. There have been, I think some of the Botox patients have had a significant improvement of quality of life and ability to be upright and things like that. The CGRP, it's only quite recent that we started a few patients on that, so I haven't got a good idea on the response yet.
And what I would say, that's just my perception of that is the CGRP targeted drugs, which are not licensed regrettably in this area. If it's throbbing, I'll be much more likely to do that. But actually, because of the fact that, that's what CGRP sensitizes nerve fibers which are on vessels, and that's why they perceive throbbing. And I think that's why I think they do a bit better. But actually, my experience of the people is much more, this is a kind of pressure. This is just a non-throbbing, sustained holocranial pressure, my back of my neck, and so I think the systems pathways and the neurotransmitters are slightly different. That's my belief rather than any data to support that. That's observational medicine, really, kind of thing. So, anyway.
And it's difficult to know sometimes whether all of the headache is related to this or not, especially in the patients who've had it for a long period of time, or the patients who've been treated for SIH but continue to have headache, whether that is different and whether that responds differently to treatment as well. Yeah,
that's where I was going to go next with my question, is about when you have patients who you might not be their first neurologist. They might have been on the merry-go-round of can you figure out what is wrong with me for a while. Maybe there's somebody who's their condition has become chronic, or they've been given the diagnosis of new daily persistent headache and they've not really had any proper investigations. Maybe you could speak to how that complicates treatment.
Okay.
Or diagnosis first.
Yeah. So I think diagnostically. So if they come to us with what sounds like a new daily persistent headache syndrome, and particularly if there's a good history from the get-go that there was possibly some minor minor trauma, and they've had an orthostatic history which has been lost over time, then we'll investigate those people and we'll treat them. We'll investigate them from the get-go as if we're looking for evidence of a CSF leak. If they've been to another centre, and that does certainly happen, we will obtain their images first of all to see what if they were what they should have been, because there are technical criteria as to what is ideal, and then we'll probably repeat those again, but we'll look to see what was there in the first instance, kind of thing. And sometimes we do pick stuff up. I'm minded by somebody I saw quite a while ago, who went to see a neurology colleague and had a brain MRI scan and was told they had tension type headache, the featureless new daily persistent headache. And actually we gave them some contrast and it lit up, and they had and I didn't expect that. And the MRI scan they had in a peripheral hospital was very few sequences. It was almost what I call an excludogram. It was, it wasn't highly T2 weighted in any way, so you couldn't even see subtle things. So if somebody comes for an opinion, we give them an independent opinion, but actually we're minded by what's happened elsewhere. The second question is, do we make a difference? Probably sometimes, yes. But actually, one of the things that we do is I know the technical skills of our neuroradiologists, and if I feel that I'm really strong on this diagnosis, but I'm not sure our neuroradiologist in terms of the invasive investigations is where it should be, I'll certainly think about seeking a second opinion on those. And sometimes my colleagues in London at the National, sometimes it's to different places in the UK. And I think that's important, because if as a consultant neurologist with reasonable experience, you've seen someone and the story is really, really, I think it's this, but actually I'm not sure they've had the right test. And that's the biggest difficulty, because we're dependent, in my opinion, on the invasive stuff, on the technical skills of the neuroradiologist. And what we've sometimes done is we've sometimes sent out films elsewhere to say, can you have a look at this? Do you agree? And that's where I think the importance of collaboration is in the most difficult people. But and that's because we don't like to not know. And I'm sure my colleagues elsewhere are the same, and that's difficult.
Because there was a question, and it's actually something that I think is borne out in the literature, that somebody's imaging can normalize over time. So they can be as symptomatic as they've always been, but there seems to be some, compensatory mechanisms that we don't quite understand, and it all looks good on a brain scan. Yeah,
that's right. I don't want to steal the thunder of the radiology people.
Okay. No, I totally agree.
But that is the case. That is the case. It's sometimes going back to the start as to what did that show. And if they've had a normal brain MRI, my opinion, I'll just put my bit in here, a normal brain MRI and a normal spinal cord MRI with a reasonable history, and the technical aspects of that MRI are adequate, we will really have to be convinced to go in and do CSF, to do CT myelography at the present time. But that's currently where we are, and we've gone back and forth before that. But I think that's the most difficult group.
Fair enough. Sanjay, do you have any more questions?
Maybe last couple of questions, because we've only got 5 minutes or so left. So it's linked to what you've recently been talking about anyway, but what somebody has asked, an interesting question: if the understanding and evidence and practices in this condition have changed so much recently, do we need to go back to all cases of new daily persistent headache to make sure that they are not CSF leaks?
Oh, wow. They won't all be CSF leaks. So the simple answer is no. But I think if someone's had an orthostatic new daily persistent headache and they were investigated quite a long time before the guidelines came out. I don't think it would be unreasonable to at least think about requesting a review around that kind of stuff, and that's not saying it was wrong in the first place. It's just what we know now and what we knew then is different. And before today's talk, I was talking to the CSF Leak Association about a guy called Mokri, Basim Mokri, who is a famous neurologist who spent 50 years studying CSF leaks at the Mayo Clinic in the United States, and he died in 2017. And as part of preparing for this, I came across something he wrote about 4 different types of headache phenotype and radiological phenotype. And actually, he was ahead of his time. He was describing lots of what we have difficulties with now, and he was struggling with them then, and that's really interesting. And some of the neuroradiological literature is even suggesting that what we knew even in 2015, 16, 17 in terms of positive and negative scans and predictive value may be out of date. So we're a captive of how quickly research and knowledge feeds back to us, and that's the most exciting thing. I'm going to be an old dinosaur, so probably I'll have stopped practicing by the time we probably have all the really good therapies and know exactly what to do. But I'm going to watch this space with joy, and I don't want all the really difficult ones sending to me. Please, can I request that now?
Sorry, Brendan, I'm not sure that's going to happen. I'm going to go for my final question, and just so that we can wrap up on time and everyone can go about their day. Do you have many patients that experience recurrent leaks?
Yeah. So I don't know what a recurrent leak is. I think if you have people, if you've had it surgically repaired, if you've had it embolized, if you've got and you've had symptomatic remission and radiological remission, I think you've got a resolved leak. I think there are people who have symptoms which relapse and remit, but I don't know if they're always having a leak. I think they're having symptomatic relapsing, remitting problems. I don't know if they've always. I've got a patient who we've been struggling with, who radiologically presented with a new daily orthostatic headache. His brain MRI on presentation had bilateral subdurals. He's had normal spinal cord MRI, and then we give him some epidural blood patches, and then it must be 3 years ago, he said, "Oh, I'm great. I'm back to my job as a postie. I'm asymptomatic. I'm asymptomatic." And we discharged him, and he came back about 8 months later, and he was worse than ever. And he said, "Oh, were you okay?" He says, "No, I wasn't really. I just got used to it and I got on with it." So I think that people are resilient and they try and get on with their lives as best they can when we as doctors can't always sort out everything. But we think he's got a CSF venous fistula, and we've just found a CSF venous fistula, and he's 8 years down the track, really. So I don't necessarily think they relapse and remit. I think their symptoms relapse and remit, but we haven't resolved the problem. That's just me. Sorry,
Sanjay, do you want to comment on that one?
No, pretty much the same. That would be by far the most common scenario, is just the symptoms would improve or worsen over time, whereas the underlying problem is not fixed. I think we've had a couple of patients who've had surgery or embolization for a fistula and then got better, and then they have seemed to have developed another fistula and the recurrence in symptoms and radiological signs. It's difficult to say whether it's definitely a recurrence or that fistula was there all along and we just didn't spot it on the first myelogram. It may happen, but it would be quite rare. So usually after you've had definitive treatment, symptoms and MRI scans are better, then usually it wouldn't come back. Yeah.
Okay, so I think that's enough of the questions for now. So you're off the hot seat now, Brendan. Can I just thank you so much for your absolutely excellent presentation, and I especially liked some of the history, because it is a relatively new condition, but obviously it's been part of human existence for a long time, just not in the literature. And can I thank both you and Sanjay for the very fascinating Q&A. I think we've gone and covered a very wide range of questions. And there are questions that we didn't cover. So just like we did for the first webinar, we'll be publishing kind of a thematic review of the questions and putting together some answers that we'll publish on the website. Like I said earlier, the recording will be published in due time. So just keep an eye out for our social media updates, and hopefully see you all again on the 8th of February for our next presentation, which is Brendan alluded to on many occasions. So that's going to be about the imaging, and we'll have a neuroradiologist in the hot seat next. So thank you again to Brendan and Sanjay, and to everyone for attending and for submitting questions. Enjoy the rest of your day, everyone. Bye.